Test. Good afternoon. We'll go ahead and get started. I think there's a few more folks that are going to get a bite to eat or whatever, but I'd like to introduce myself. My name is Perrin. I'm currently the Emergency Management Coordinator here at Mary Greeley, and we're going to go through the obligatory things here. My first disclaimer is that any fuzzy or autofocus slides are the sole responsibility and error of this program's presenter and should not be construed as an attempt to influence by Dr. Talbert to increase McFarland Clinic Eye Department traffic. Generally, it's just kind of a combined background disclosure. I'm a American Heart Association instructor for about 30 years. ACLS came into being in 1976 as a physician-only class. They quickly recognized that we need to involve allied health professionals, so within a couple years after that, they started doing it, and that coincided with my entry into emergency medical services as an EMT and paramedic, and got my instructorship and survived the early years. How many of you took ACLS, say, like 20 years ago? Torture. Absolute, sheer, abject torture. Had to wear a diaper, right? Because of the way it was constructed. It's whether you survived ACLS. Just to show that it's not a one-sided deal, the American Heart Association, ACLS and BLS instructor, that's what I currently am, but I've also done teaching and been certified as an instructor through the National Safety Council, the Emergency Medical Products, American Safety and Health Institute, and the Iowa Department of Public Health Bureau of EMS. I'm currently on the State of Iowa EMS Advisory Council and their Quality Assurance Standards and Protocols Committee. And it's not really a conflict, but a disclosure. I was involved in us getting 2 devices that I'll talk about. Not here to promote them in any way, shape, or form, but need to let you know because they're in the area and in use, and you may run across them. That's the Lucas 2 and the Rescue CPR system. Okay, so I kind of categorize that EMS piece as kind of a dry land lifeguard. You know, we go out and try to provide care. And in its inception, EMS was all about you call, we haul, that's all sort of thing, where bystanders just had to know to call 911, and we would show up and we would do everything, load the patient up, keep doing everything, and get them to the hospital. And it's certainly evolved and flattened out and included the lay public, and we'll talk about that here today. Also, by way of background, it kind of factors into some of this in terms of the teaching and all. I've done graduate work in experiential, not experimental, experiential education, particularly how people learn, communicate, function, and reflect under duress. Been some interesting studies. And in addition to the lifeguard, the laugh guard part, I've been an editorial cartoonist actually for the Ames Tribune for over 30 years. Once a week, I have my homework assignment, and I fully believe that in this the bottom quote, if you haven't got a sense of humor, you haven't got any sense at all. Although there are appropriate times to display that humor and times when you shouldn't, but hopefully some of that is scattered throughout the presentation, or else it's really heavy stuff. And here's an example. I don't know if you can read it or not. I did 2014. It's paralyzing and perplexing perceptions, potential plague, and it's the guy here is asking, what's a 5-letter word for something that's starting to spread, highly contagious, debilitating and deadly, fosters headline striking fear, preying on the hearts and minds of Americans? And obviously the woman says, easy one, Ebola. And actually, no, the correct answer is panic. And there are 2 vaccines for it, also 5 letters, facts and truth. So every now and then I get a chance to inject a little bit of the medical side to the newspaper work. So I don't think this is going to be, by the way, I wanted to use one of the new GHS, the Global Harmonizing System, warning icons, slightly modified with the human brain in it for so I can get extra credit as far as my emergency management stuff. I don't know if there's going to be a whole lot that's earth-shattering, but these are unusual times, and a lot of what I'm going to be going through, or really everything I'm going to be going through, is based on something that was published last October, usually to great acclaim, or at least great fanfare and scrutiny, and I think it just missed for whatever reason, a lot of people didn't know that there was a change or a series of updates, and so we're going to kind of go through and bring everybody up to date. So kind of consider this an introduction into ACLS and BLS. So I thought it was one of the most anticipated events last year. Clearly there was something else that people had their attention on, and maybe that's what really led people to be distracted. But as I said, it was published in Circulation magazine. It was free. Normally it's a subscription-based magazine, but this stuff was free, is free, and is readily accessible to anybody that wants to check into it. And again, I readily recognize we have to be very careful what we put into our heads, because it's very difficult to get out. We learn how to learn, hopefully. We don't always learn how to unlearn. So a quick test. See how fast you are. What color is a yield sign? Yellow. No. Actually, the last time a yield sign was yellow was 1981. It is currently red on white. But 75% of the people answer yellow because they first learned it that way and have not, even though hopefully you can see and recognize it, haven't unlearned some of that information. That's probably the number one complaint about ALS and BLS, is it's always changing. Why is it always changing? Fundamentally, we can't get enough large populations to study that are willing to be, to have the controls and to go into cardiac arrest and then let us study them. So it's a lot of difficult, smaller scale studies. And so as we get information, it changes, gets updated. This publication, I want to alert you to, if you haven't heard about it. Anybody see this or hear about this, Strategies to Improve Cardiac Arrest Survival, published in June of last year. Institute of Medicine. This actually might be a bigger deal than the ACLS, BLS publishing, in that the Institute of Medicine, in cooperation with just about everybody, a veritable who's who in the Heart Association, the Red Cross, a number of other scientific physician organizations, so on, came together over a couple years, and this came out. This is essentially a white paper that says we're not doing a very good job. We're stuck on single-digit survival rates across this country for cardiac arrest. We have been for decades, and that's not acceptable. Basically, what this comes out and says, it's not acceptable. Generally, not always, and certainly given our current climate, I can't predict. But usually, when white papers are issued like that, there's a funding initiative after them and a real effort to try to move the ball, so to speak. And part of what is captured in here, in addition to some new models and new directions, is the challenge that, yes, we have to base everything on evidence-based medicine as a platform, but in particular with cardiac arrest, we have to carefully, but with a certain amount of bravery, take on, kind of new challenges, again, because where we are and where we've been hasn't really moved that indicator very well. And so you will see a number of things that are kind of crosswalked from, and I'm not going to go through this particular document, I just want to reference it, but as an overarching concept, the new guidelines fit right underneath this and embrace that. So, forward. This is what it looks like if you were to get a print copy. I'm going to show you here in a second. You can access it, like I said, for free. What they did it very differently this year. Every 5 years, for the past 20 years, every 5 years, the American Heart Association has come up with this plan to publish. And so it was 2010, prior to that's past year. Prior to that, it was 2005. And so on. And so people kind of look forward to the changes being distributed every 5 years. Well, one of the new things is there will be no more every 5 years. It's now going to be put out on a rolling basis. And people have to be aware or dialed into some of the key publications. And if you're part of the network, either through the American Heart Association, Red Cross, American College of Emergency Physicians, they'll all be notified as there are significant findings from the ILCOR, the International Liaison Committee on Resuscitation. So one of the key things to tell you right now is that they decided they weren't going to try to reinvent everything. So instead of reissuing the guidelines, we're really not even supposed to say that last year. There wasn't a guideline that was issued. It was actually an update. So a guideline is kind of a wholesale inventorying of everything, reviewing everything, cleaning it up, and putting it out there again. And actually, about the 18 months to 2 years prior to the publishing last year, the work that they did, they said, we're not going to do that. We're not going to keep publishing things that haven't changed, or that the last version of this, 2010, we don't have new evidence. There's not a lot of controversy or questions. There's no reason to restate something of those two natures. So what they did was, instead of taking the 280 or 260 some questions, I think they cut it by about 30 or 40%, and they looked at where's the new science at that they can comment on, and then also where is it that they need to reiterate what isn't necessarily new, but there's controversy in terms of maybe clarifying the language. So that's kind of where they focused their efforts. And then they also used a new for them, system that in terms of evaluation. They went along with kind of the national or international grades standards for evaluating evidence, so that it was in alignment with researchers doing other forms of research. And then they've organized a publishing arm, if you will, called SEER, S-E-E-R, that is the way in which they're going to kind of broadcast or be the mouthpiece for what they publish. So what they want you to do then, and this is talking about the context of the changes. I know some of you are here to say, just tell me what the changes are. And I will tell you this, it is dangerous to do that. First of all, the new updates don't cover all the guidelines. They're just covering kind of the high points, if you will, or the things that needed comment on that they felt. And then if you just look at the summaries, and your handout here probably looks a little different that you got for this program, because the shortest handout that you can get for the guidelines, it's official, is 36 pages long. And so a lot of people go to that, and that's still a highlight. So I will tell you, I'll point out in here a couple of places where if you just read the highlights, you're probably missing the message. An example might be vasopressin, just to jump out there for a second, because if you look at it or read anything about the new updates, they'll say, well, vasopressin's not recommended anymore and it's not included. And so a lot of people are just taking it away, dismissing it outright. There may be a place for that, and we'll talk about it. Okay? But you wouldn't find that by just simply looking at the highlights. So really requires some attentive reading, if you will. Okay, so we're away from these 5-year periodic updates to this new, what they're calling a web-based platform. This is the page that if you were to launch, and at the bottom of this I've got the URL for it, and again, because of partly, as you see when you go through this, that just getting the handout doesn't make that much sense as the highlights that you have there. If everybody wants this, just let me know or let DRLS know, and I can get you this PowerPoint to getting this kind of information. But you land on this, and so they'll give you the official update. You can get the narrative that's in Circulation Magazine. And then the web-based integrated guidelines is where they are taking the new stuff and putting it in with the old. And this is a transparent process. As much as people say, oh God, this kind of surprised me that all these things changed, the process is always transparent. In fact, they publish the questions before they even begin investigating them, and then the evidence itself before they reach consensus is available as well. You just have to seek it out. And again, most people aren't really interested. It's just give me the abstract or give me the highlights. And so anyway, it's available comprehensively. They also have products now that you can download into your your electronic devices if you want to remain wireless but still have the reference stuff. So all of this is free. Okay, so this is their quote from 2010, the publication. Many lingering questions about CPR, BLS, and ALS remain. So they focused on things with significant new science or controversial subjects that they just needed to weigh in or check in with everybody on. So at the bottom, in their situations where no new evidence existed and there were no changes in the previous recommendation, they just rolled on. I think a copy of this is in your handout, and I'm sure you probably can't see it very well, but they've got this classification system that aligns better with the grade language, if you will, and it has to do with green, which is very strong Class 1 recommendations. There's clear evidence, great studies that support it, all the way down to Class 3. In Class 3, there's actually two. They're only showing you really one. One is a Class 3 harm. There's another kind of a subcategory of this, and that's Class 3. There's pretty good evidence, but it doesn't seem to do anything. Sort of a classification. But as you'll see, great classification system. We have very, very, very little evidence of a Class 1 nature for the findings, the guidelines. And it's probably why they call them guidelines and not standards, is that in some cases it's a lot of people getting together and trying to pick the best possible answer, not necessarily the one with the greatest evidence. So the strength of recommendation, the level of evidence, those are the two indicators there. And here's the slide that kind of points that out, that and now they say here, and it seems like it's confusing because I said it was only about 160 issues, but from those they gave more recommendations than a single one on some of those issues. But if you look at the classes of recommendation, this blue sliver is the one that's Class 3 harm. There's Class 1, Class 2, then Class 2B, which is unclear, and then this new class I said, the Class 3, no benefit, that they put that category in there. But here's the evidence behind it, and the level of evidence that's clearly superior, gold standard, it's 1%. 1%. So people might speak with conviction that this is the thing to do in cardiac arrest. In truth, there is not that strong of evidence there. So again, there's more about that on the website. I also wanted to pause for a second because amongst the things that they introduced, and this isn't on the website, but this is how it translates, they were concerned about the education piece. The idea that the course and that knowledge is in 2-year packets. They readily admit there's no science to support that. It's kind of more of a business decision or a matter of convenience of what institutions will tolerate in terms of having people recertify. But in fact, that people need shorter exposures more frequently to really get the psychomotor skills that we're expecting them and the cognitive recall that you're wanting them to do, particularly in stressful situations. So they had some recommendations for the educational process. So this is just about how things may change if you bump up against how we do it here, and how we do it here is actually an echo of how it should be done by most above-board, ethical, connected training centers. And that is, cards are only distributed by the education controllers, if you will. They can't freely distribute and hand out blank cards. They have to be, Item 1 and Item 2 just go through the details of those cards, but in essence, they come from here. They come from two people that are really the gatekeepers for all cards and all cards that go to all courses from here. Interestingly enough, the challenge course. So you could challenge ACLS or BLS by saying, you're just going to walk in and do it. I don't need anybody to lecture, update, do anything else. I'm just going to walk in and do it. It's now, there's a moratorium on that as they make sure that everybody gets the new information. So there's no challenge courses for the next 2 years. The renewal course for BLS healthcare providers has been eliminated because the original and the renewal are close enough together. They're combining it. Interestingly enough, in ACLS and PALS, there is a pre-course assessment. It is required. It's also electronic. So it must be completed prior to the course. Obviously, the title pre-course. So that's a requirement now for ACLS and PALS. And the manual or the reference that you're using will clue you into where you can get that pre-course assessment. And maybe this is a huge positive here. All exams are open book. And the idea that when they had people taking some of these courses available online, the first half of it, not the skills part, but the first half of the course, you could access books when you took it online. In fairness, they said then the people in person should, when you're taking the course person to person, you should have access to resources. However, they say now too, it's open book, open resource, but they can put time limits on it. So it's not like, hey, here's the test, I'll come back tomorrow. So you can, having never looked at it and have no idea what you're dealing with, get through the test. There's an expectation that you have some preparation and know where the stuff is at. And they're rolling out course materials. Now, this is all the content, the course materials that support this. Both the Red Cross, a lot of private providers, the American Heart Association are rolling those out in increments. The first increment actually was yesterday. I think they released the BLS stuff because that's the largest population is the BLS providers. Then I think the next thing that we're expecting is ACLS before summer or the start of summer. So ACLS support materials, textbooks and stuff. And then they've got PALS. And that's kind of the major courses I think that are out there. So back to the mainstream here. This is the kind of the table of contents. And what's new, all of this stuff has been there before, with the exception of systems of care and continuous quality improvement. And this came out of that Institute of Medicine study, if you will, or collection of studies and consensus statement. And that is, how do we know we're doing the right thing or that we're improving unless we measure it? And so they're really calling for a lot more measurement, a lot more CQI, a lot more work towards improving resuscitation systems and efforts. So I'll have just a couple things later on, I think, maybe to relate to that. But just to note, this is a new emphasis. So that includes feedback devices, that includes post-code reviews, debriefings, and then formal reviews. And just, again, not an effort to get anybody in trouble. It's to improve the process. Look and see where we can grow and we can learn. Okay? And then as far as what I'm focusing on, this is way too much for one session, so I'm really focusing on the adult, and we're looking at BLS and ACLS, and even that, there's a fair amount on dysrhythmias and things like that. I'm focusing primarily on cardiac arrest. The real, we're going to get our underwear in bunches sort of thing, where if it happens, it's unexpected, and we need to marshal resources and try to follow kind of an alignment of principles and direction. So let's start with this by talking about the layperson, because what my introductory comments about EMS and about organized responses back in the 1970s was when you call the ambulance, they bring everything that you need when it's out of hospital. And in hospital, it was a code team that's supposed to be responding. That's still the case, where I think in a lot of people's minds, but really this thing is flattened out to where to get your safest, fastest, biggest difference makers, you have to train bystanders. There's just no way around this. You cannot drive fast enough. You cannot run, especially our facility here is even bigger geographically. We were doing some testing on violent patient responses, and to get 5 people that are trained from the South Tower and the ER to the West Tower was 4.5 minutes. You think, well, that's not too bad. Well, try holding your breath for 4.5 minutes. That's a little bit harder to deal with. So we have to deal with and train people, and they have to be competent in the initial actions. And that's for all you here. You're thinking in a clinical context, but remember, you're seen and you hopefully have time outside of this where you're involved in other activities. And as a medical provider, hopefully you can bring some of the findings from the guidelines to bear in those initial efforts. To do this, you gotta, and you probably all heard the stories, people that took CPR in the past, the public, those that had the courage to take the course, as they pulled them when they exited the course, less of them were willing to do it after the course. You would think with training that people be more willing to do it. But, you start talking about broken ribs and vomiting and decapitation and all this, and it's like, whoa, not for me, right? So what they did is they looked at the educational process and really what's important and what really makes a difference and so on. And it's now gone from a 4-hour or 8-hour course for the lay public to a coffee break. The Heart Association, and it's sponsored by others. I just kind of use that because that's where I get a lot of my information. But there's this compression-only CPR. How many have seen commercials for it or references to it? Compression-only CPR, they're 1-minute videos. Some of them are with famous actors, personalities, or whatever. But it basically says, it's all in that little square up there, is call 911, and on teenagers and older, push hard, push fast, with complete recoil. That's it. There's no other great explanation. In fact, people can take this and not even do any practical part, although they're encouraged to do it. It's to get them exposed and see if they're more willing to do anything. And it's kind of sad to say that we'd rather have them do anything rather than nothing at all. I'm not sure that's entirely true, but at least this is one step towards breaking down their fear and their preconceived notions about it by having them in an entertaining way get exposed to the concept. So what a lot of folks are doing is getting bigger groups together for basically the length of a coffee break, show the video, and then have a bunch of mannequins or, honestly, little round balls that are fairly compressible, those little indoor balls that kids kick around all the time, and having people practice on that. That's it. So, it's trying to get them in the door with as simply as possible. They've also have a real focus on 911 dispatchers that are kind of hesitant about providing instruction. And if you provide instruction to somebody that doesn't know CPR and include about rescue breathing and all that, it takes them way too long and it's way too slow. So it's really compression-only CPR taught over the phone by the dispatcher. And they added some clarification because a lot of dispatchers, which are not medically trained, get confused when the caller's talking about gasping or breathing, but it's irregular breathing. And again, they simplified it for the dispatchers and have that training available. There's a caveat, not that we're necessarily encouraging this, but AEDs are designed, have been from their outset, to basically be what I would say paramedic/physician proof. In other words, we can't make it do something wrong. It is designed to only, basically when you put those two pads on somebody from an AED or one kind of contiguous pad and some of the newer ones, it will, in the time span of about 9 seconds, do 3 overlapped views trying to pick up something in terms of pattern recognition for normal heart activity. And if it can't pick that up, and it doesn't also pattern match for artifact, it's going to tell you to shock the person. So it'll tell you to shock. They don't tell the public this, but most of them are designed to shock any VTAC, which is organized at a rate greater than 175, but also anything that looks like all the variants of VFib. Can't make it shock anything else. Okay, so it's designed to do that. The machine basically operates itself if you slow down. Where we get in trouble is we push the on button and then start to do stuff thinking that we're anticipating the next steps. And really, the public's really good about this. Just show them where the on button is, or they can find the on button, and then the machine prompts you through the steps. So it is now in the language that if they don't know, they should not be discouraged from trying the use of the AED anyway. And somewhat controversial, there's now a section and even a little algorithm for naloxone administration for opiate overdoses. And we don't see, I would tell you on that advisory council that I sit on, Cedar Rapids is having some trouble. Iowa City, Davenport area, they've seen some problems with the overdoses in terms of frequency. They've also seen some complications with Narcan. And so, the physicians on that board are kind of looking at this carefully, but Narcan or naloxone is available over the counter. You can buy the kit, and now that it's available, the price is going up, just like everything else, so we'll have to see where it ends up at, but it's nasal. They've got the atomizer on it, and it's a nasal dose that you can administer. And here's a shocking fact, I think. More people die from opiate overdoses than from car accidents in our country today. That's pretty scary. More die from opiate overdoses than from car accidents. So maybe there's a place for it. We'll see. But there's certainly the education and the endorsement, if you will, to move forward with this particular issue. There's also these new frontiers. So they've got drones that they're looking at that can drop AEDs, because it's one thing to get a bystander to do CPR, but a $1,500 AED is harder to come by. So Uber's in the market, and they're looking at drones as far as being able to rapidly deploy it. And interestingly enough, there's this new software that's available for dispatch centers where people can electively enroll that I know how to use an AED and CPR, and it gets stored in there in terms of that information. There's a cardiac arrest. They can send out the message either blanketly, or if you've got GPS, they can locate you and call you. They can do the same thing, and they've got it mapped out to where it's within, I think it's like 1,500 feet straight lined to that location, or it's like 700 feet if you have to go get something. I mean, they've got this thing out, and it's been deployed in a few communities, beta tested, and so folks are looking at that. So all this is built around trying to involve the public or off-duty medical people in getting the response as soon as possible. And most of you, if not all of you, have heard the story of our own mayor. I'm talking about the mayor of the city, not the mayor, but the mayor of the city who had cardiac arrest. She's very open talking about it. Had a cardiac arrest at a car dealership. A bystander started CPR. Law enforcement was nearby. They have an AED. It's interesting, this is right next to the fire station. The fire station was otherwise occupied, but law enforcement was there. So we've got this redundant system. Got the AED on, shocked her. Our folks showed up, had to do an additional shock. She, I believe, had a period of hypothermia that they induced, and she's obviously back in office today, so she's a great spokesperson for this. And it's a testament to the public and their involvement. And I think Julie, we have one of our own nurses that a few years ago experienced a similar sort of episode. So we need to continue to do that. Iowa State University, a shout out to them, 140 AEDs scattered on our campus, and they're growing at a rate of about 5 to 10 AEDs every 6 months. So we're seeing churches, we're seeing a lot of people buy into this. The two big things are the CPR and the AEDs. Okay? Guidelines have now split when we talk about the recommendations. I'm moving on beyond the lay public and talk about the medical community. So now you have out-of-hospital cardiac arrest and you have in-hospital cardiac arrest, and guidelines now diverge when appropriate. And it's basically around the evidence. They're saying that out-of-hospital cardiac arrest evidence supports maybe different priorities, and in-hospital have maybe better studies in other areas. And again, we'll show you a couple of those options. Okay, so sometimes you get all the guidelines and everybody thinking they know what to do. It seems like this. You've got an awful lot of people shouting and not that many people doing. And this is my scaled model. When you take ACLS now, really ACLS has an awful lot of focus on BLS. And it's really moving towards high performance, kind of choreographed, a lot of communication, and saving seconds. I think we've been very forgiving in our expectations of people suddenly responding, but you start to read the guidelines and where they're finding the evidence. It's in getting right away, starting things right away, doing a great job of that, and not interrupting that great job to start doing some of the distractors, and they call them distractors of ACLS. Okay, so basically the BLS algorithm, this is for healthcare providers, remains virtually identical. What they did do, though, which is, I think, a good thing, is that they recognize finally, even though you teach things in a linear fashion, it doesn't always happen that way. That they do, it says, acknowledges the actual resuscitation attempts often do not follow a linear and sequential approach. What this means is that initial part where we used to make people tap and talk, open the airway, look, listen, and feel. This is taking you back a little bit. Then, calling for help, AED, and then checking for the pulse. You can do those things kind of at the same time. You can open the airway, check for the pulse at the same time if that's how you're so inclined. It's kind of clustering the initial quick assessment. That's now allowable. It frustrated a lot of healthcare people because you learned it as a cluster or you practiced it as a cluster, but they wanted you to demonstrate it in a linear fashion. Again, though, the key is to get compressions going as soon as possible, get circulation going. Choreographed responses are really, in particular, where this has been pioneered as EMS, and something that they call pit crew CPR. You guys are familiar with race car driving or races where they've got a pit crew, and that pit crew, professionally, they do that full time, and they're shaving fractions of seconds off their responses. And they're saying that we might want to consider and adopt some of those practices so that we can be more effective in our resuscitations. So let's see if this will work. I'm going to show you, this is from Alina Health up in Minnesota, where they took pit crew CPR, which has actually been in EMS for maybe about 4 or 5 years, and they're going to demonstrate how they do it in the hospital.
This is a quick demonstration of this pit crew CPR model. The first person who recognizes the cardiac arrest calls for help, calls the code, and then starts manual compressions. One difference we're implementing at the recommendation of the Minnesota Resuscitation Consortium, which is part of the National Heart Rescue Project, is to do continuous chest compressions in all patients, even if they do not have an advanced airway, so no more 30-2. Second person gets there and starts ventilating the patient with the rescue pod, and be sure you follow the timing lights and don't hyperventilate the patient. One hand squeeze of the ambu bag every time the timing light goes off on the rescue pod. If a second person or third person arrives, you should try to do two-handed face mask seal to get the best seal possible. So one person bags and the other one does a two-handed face mask seal. Additional person comes into the room and operates the monitor and defibrillator, so gets pads on the patient and gets ready to defibrillate. You want to rotate manual CPR every 2 minutes or every 200 chest compressions. Be sure to allow full chest recoil to maximize the negative pressure in the chest on the upstroke, which ensues or brings more blood back to the heart. Here they're putting the backboard on for better resistance for chest compressions. This next video demonstrates when the code team comes, how you transition over to that. So a quick report will be done, code leader gets identified, and the code team members will take over compressions, monitor, and airway.
We're in asystole. Okay, switch chest compressions. We've got someone on the defibrillator.
Yep.
Okay. And pharmacy is on their way.
This is a demonstration on how to transition from manual CPR to Lucas CPR. Remember, chest compression interruptions less than 10 seconds for any maneuver. And we found that with a patient in the bed, it's easier to lift them up to put the Lucas backboard on rather than to log roll them. Chest compressions continue as the Lucas backboard is placed. Then Lucas is placed really through the arms of the person doing manual CPR and attached, and then it is turned on, plunger lowered in place, and Lucas starts. As you'll note, each interruption of chest compressions was less than 7 seconds in this demonstration. So that's how to transition from manual to Lucas CPR. Thank you.
So that that ITD, what they call the rescue pod, takes an average of lights up every 6 seconds. So they were saying, how often do you ventilate with that device? And this is just one way of doing it. So this pit crew, there's a BLS layer to this and an ALS layer, and it's exactly where do people go and how do you eliminate interruptions.
Mr. Smith. Mr. Smith, are you okay?
Mr. Smith?
I think I've got another.
He's not breathing.
I'll call the operator.
Can we get some help in here?
Yeah, thanks, Tim. Okay, Tim is now controlling my slides. By the way, we do have the Lucas device here. We have it on all the ambulances, and we have it in the ER and the ICU as part of the response. There's the standard board that you saw them use, and this is the radiolucent board. So if they go to the cath lab, they need to have this. That's another $1,500. That was a little value-added experience that we have. So the Lucas device is one way of providing the consistent compressions that you need. Here's the kicker. It's not recommended. It's not recommended in the new guidelines. The science that they had said that it took too long. They inferred that it took too long to set up the device, and it wasn't the device itself, but people weren't familiar with it, that you have to get it on, and that's why the physician was talking about 7 seconds. Those that have the most experience with the device have found that outcomes are best if there's no interruptions of any sort of CPR longer than 30 seconds, of any sort, and at one time, and clearly the 10 seconds. So the recommended compression rate is still at least 100, but now they have an upper limit. Don't go more than 120. Most people actually push 120 to 130. So be careful that people are going at, and I think generically they've talked about, see, I blocked out so I wouldn't endorse the group that sponsors this, but the music Staying Alive. So I'm trying to, like I said, dilute, and then clearly I should have blacked out their faces and stuff too, so you could see that. It's kind of ironic because they're not staying alive. A person that's in cardiac arrest is dead, but the music is a little more hopeful, and it's got the beat that they want you on for that, right? So now it's not too fast, not too hard, but it's also not too deep. Here's the problem. They want you to go at least 2 inches, but they don't want you to go beyond 2.4 inches. In fact, the research actually said 2.6, but the guidelines came out with 2.4. How the hell do you measure that? So then it comes out that if you're going to try to be in that, then you need to look at, jumping ahead here, you need to look at some kind of device that will give you feedback. So here is an example of such a device where you turn it on.
Stay calm. Check responsiveness. Call for help. Open airway. Check breathing. Start CPR.
And now it's pacing you. And if I'm not doing,
Start CPR.
see, I'm not starting it. Let's this is not the way I would really do it. I'm just showing you that.
Push harder.
So it coaches you, right?
Push harder.
Please, God, give us Siri or some different voice than that. Okay, so we've got something that'll help coach with those. Now, but there's variations, and you heard the doctor from Melina talk about that. The guidelines say that even though we're still going with the recommended 30 and 2 because we don't have evidence contrary to that, also seems to be evidence that supports 200 consecutive compressions, uninterrupted, followed with defibrillation. And the little blurb to save you the reading time for Seattle is they do 200 compressions, defibrillate, and if they don't convert, they do 15 seconds, shock again, 15 seconds, shock again until they get a conversion. So people are developing these little areas of excellence where they're going above and beyond just the basic recommendations. So continuous chest compressions is an opportunity for variation, if you will, if you think so. Here's the thing, CPR fraction. The time that you spend doing compressions for a person in cardiac arrest should be absolutely no less than 60% of the time, and they recommend 75% of the time that you're continuing to do the compressions. The other thing is the delay from the time that you stop doing compressions to the time that you shock. Let me give you, if you do it within 5 seconds, you're likely to convert the rate on the order of magnitude of 81% of the time. If you go through the whole, like an AED, which you cannot hurry up, but an AED that goes to 14 seconds has about a 41% conversion rate. So they want you to shock as soon as you can. And this is just a reference to, hey, let's shock while they're still doing compressions. Let's put some gloves on them and let them keep doing compressions while we shock. Or if you use something like the Lucas device, you can actually shock while the device is in operation. So it's having that going as much as possible. They finally answered the question that, yep, high flow oxygen during CPR is fine. Once you get the return of spontaneous circulation, then dial it down for that saturation level. There's an example of that quality demo I just gave you. One other device to show you here real quickly. You can come down later if you want to play with it. This we have with some first responders called the rescue pump, the only FDA-approved device to increase survival in cardiac arrest. It's a suction cup, and it's going to pace you, and you have to literally have a mannequin that's tied down to practice, because otherwise it'll pick the mannequin up. This is an active compression and decompression device. So another tool that's out there that's got some evidence behind it, and in fact that's what this lower part from the guideline says, is that in a randomized controlled trial using the ITD and active compression decompression improved neurologically intact survival. Okay, maybe I can't advance my slides now. There we go. State of Iowa just announced a couple weeks ago, $6 million to buy this device. $6 million worth of those devices from a grant. 700 of them will be coming into Iowa to hospitals and EMS services. So there's a renewed focus on, and this is just the article on it, you can read that later, but mechanical CPR devices, the reason that they are not showing superiority, they believe, is inadequate training and long pauses. So no time for that. Here's some other kind of points to wrap this up with. Ultrasound's been added as a way of confirming the E2 tube placement and return of spontaneous circulation. Capnography is now mandated. It's not recommended. 2 comments on drugs, and for those that are focused on drugs, never been an antiarrhythmic medication shown to improve long-term survival. Never been a vasopressor that has shown increased survival. The 2 drugs that we focus on, and I'm not saying not to give them, it's just the focus over maybe CPR and everything else, there's no evidence to really support that. However, the guidelines have offered that in terms of the question of epi or vasopressin. Vasopressin is difficult to draw up, except now that we've just been alerted that we have a shortage of the pre-filled syringes, so you probably have to draw that epi up as well. So what they did was they removed vasopressin, not because of anything that it did poorly. It just never acted differently or increased survival rates, supposedly. Although here's a real interesting thing that's in the study, hence you have to read beyond. Vasopressin is no longer routinely recommended. An interesting study, there's actually been a follow-up to this. Vasopressin, epinephrine, and steroids significantly improve neurologic survival for patients in cardiac arrest, in hospital, not out of hospital. And so it's an acceptable alternative. So before people throw it out, you have to consider, look at the research and see if there's a place for vasopressin, but also including initial dose of steroids. So generally, this is the statement you see. It's been removed from the algorithm altogether. That's absolutely true for out of hospital. In hospital, there's still a consideration for it. Epinephrine, here's the concern, is timing. The average initial dose of epinephrine is given 22 minutes into a cardiac arrest. It's too late. It needs to be within the first couple minutes. So, and the amount is still in question, and certainly the underlying pathology of the patient may impact based on whether they had an MI or some perfusion issues. So, routine use of lidocaine is now out. You only got 2 drugs in cardiac arrest. It's epinephrine and it's amiodarone. And amiodarone only if they're in refractory VF, right? They want PCIs on patients for STEMIs and hemodynamically unstable or electrically unstable patients without the ST elevation. Targeted temperature management's now increased the upper limit, so it's now between 32 and 36 degrees Celsius. Fewer complications and acceptable outcomes with 36 degrees. And with that chilling statement, that's the new algorithm right there. Doesn't look an awful lot like the old one. There's just a few, the same H's and T's, the same general guidelines, only 2 drugs. Again, put them in perspective. Do great CPR. Great things will happen. Okay? And my last statement is this. Research needs to continue. Difficult to study without adequate size populations. Animal studies are out because of the ethics. Next, they were considering lawyers because there's a lot of them and people don't get quite as attached to them. I now submit to you, maybe we need to look at presidential candidates. We've got an awful lot of them. Anyway, that's it. Thank you. I'll stick around if you have any questions.